we're going to talk about the psychiatric patient. I'm not including pediatrics, which is a whole nother area. Unfortunately, very little staffing is available in it, also very little funding, but we're going to stick with the adults for now because they are the majority of our patients. Downstate and the residency has a huge place in my heart, and I'm really excited to get to know new residents. So we have a few objectives for here. We're going to go through a quick ED evaluation. We're going to discuss a couple of the things that you need to know. There's some newish literature on this that I think we should consider, and I want to really combat the idea of medical clearance. I want to change your entire attitude toward it by the end of this 30 minutes. So that's my big goal. So in 2019, approximately 3.8% of individuals on discharge had some form of mental illness based in their discharge. That really hadn't changed a lot from 2009. In 2020, with the pandemic, the numbers actually went down a little bit, but since 2021, they've been steadily increasing. Unfortunately, the CDC is not going to collect these numbers anymore. So the numbers we have, the latest we have is only from 2024. And I don't think we're going to see any more numbers until at the earliest 2028. So this is what we're dealing with at this point. Suffice it to say, there's lots of people that are coming. It's mood, anxiety, suicidal attempts, all those things have been increasing. There's all kinds of reasons for it, but that's really not what I'm going to focus on here. We can talk about that at another time. What is the goal of you or me and us in the emergency department? We have really one major goal, which is to identify, is this an organic thing or a functional thing? We really need to know that. And the entire medical system is counting on the emergency department to make this determination. They really aren't a lot of other people that are doing that. Psychiatry can come in if we say, hey, they're organically in good shape. But before that, it really sits on the shoulders of emergency medicine. And so I think it's really an important thing to understand. So the psychiatric assessment, safety and stabilization, absolutely like anything else in emergency medicine, is our first thing. You want to try to identify homicidal, suicidal, or dangerous behavior. Not always possible, but that is a big goal. The medical evaluation of this patient is really important. Just because they have a psychiatric disease and illness that they've been carrying around for maybe anywhere from 5 to 50 years does not mean that they don't need a medical evaluation as well. And then you want to get the psychiatric consultant in to talk to them, to talk to you, and to make the best decision and disposition for this patient. So safety, 10% of patients are going to be violent. Sometimes it's more, sometimes it's less, depends on the time of day you work. Verbal de-escalation, for me, it worked about 40% of the time. So 60% of the time it did not work. Everybody has a different way that they deal with these patients, and I'm not going to make any kind of a judgment on that. Awareness of the risk factors and warnings of violent behavior is something that as you get more and more experience, you start to have a sixth sense on, like, this guy is not going to be easy. This person is really dangerous. Also, you always want to think about the patient who absconds because you really don't want them running out. Then emergency access to medications, and Noah talked about that. Sometimes it's not so easy to get a medication, so you want to make sure that you have this readily available to talk to the patient about. Sorry. When you talk to these psychiatric patients, and they may or may not be at that point, you want to have a little bit of distance from them. Do not invade their personal space. You're not going to touch them immediately. Avoid direct eye contact. People who are having schizophrenic breaks or are in a major depression or manic really find this intimidating. Try not to do it. Maintain a somewhat submissive posture. You're going to get a better history and physical if they feel that you are not over them, but equal to them. Stand in a location that neither threatens the patient, nor blocks the entrance, nor puts you at risk, and allow your patients to verbally ventilate. If they need to scream about how EMS mistreated them on their way in, let them do it. It's fine. At the same time, set acceptable boundaries. You can't touch me. I'm not going to touch you right now. I'm going to talk to you, but you can't touch me. Things like that. You can't get out of the chair. You have to stay in the chair. acceptable boundaries, not things that are unreasonable. So what do we need to do? What are the organic illnesses that we need to identify? I put some strength into the fact that it is on your shoulders, on our shoulders. Dementia, delirium, chemical intoxication, and chemical withdrawal. I want to thank Noah for going into alcohol withdrawal at great length, and so I'm not going to go into any of that at all. The most common non-organic disorders are depression and schizophrenia. That has not changed in 50 years. So think about, do they have a fever? Is there head trauma? Are they immune compromised? It used to be they always, when I was training, immune compromised HIV, immune compromised AIDS. That's not true anymore. We have an incredibly immune compromised population generally. People are on all kinds of things, or they're immune compromised to begin with. So we have patients on immune modulators, we have patients with transplants. It's really something that you need to think about. You need to look at the advanced lupus patients. Very large population in East Flatbush of lupus patients. They do have psychotic breaks. You need to think about those things. And then diabetes, toxic ingestions and overdose. You want to also think about what drugs they're on, either illicit drugs, over the counter, and then there's always the herbal medications that make for a good CPC. Substance abuse, it's a higher incidence in any chronic illness for self-medication and substance abuse. Remember that. If one diazepam works or one Xanax is nice, 5 Xanax might be better. You want to think about these things. Neurologic symptoms generally do not present in psychiatric patients. And please remember, generally, they also can. So this is not, and we're not talking appendicitis, great imitator, but you can kind of be comfortable. Dizziness, disorientation, confusion, headaches, focal weaknesses, and difficulty performing routine tasks. I really like the difficulty performing routine tasks the best, because if you ask them to do something that uses their fine motor skills, their large motor skills, and function on it, that is a pretty good indication of what might be going on with them and whether or not this is a functional or an organic illness. Mental status examination, you guys have had this millions of times in your medical school and I'm sure in other places, but please don't forget, abnormal vital signs are abnormal for a reason. However, that doesn't mean that they can't be tachycardic and hypertensive if they've been restrained for the last 4 hours. You need to look at the whole picture and the whole patient. And disorientation and clouded consciousness, if they're under an influence of some external cause, be it drugs or something else, then that can also be a reason for it. So all those things go with it. When I was training, they always said visual hallucinations were organic and auditory hallucinations were functional. That's not necessarily true. There's all kinds of hallucinations, and you can't really hang your hat on one or the other. What you can do, though, is patients over 40 who are having, without a pre-existing psychiatric history, if they're presenting in a psych form that you don't think that it has to do with drug abuse or use, then you really need to think about what's going on and is this a mental issue, organic rather than a functional. So this is the regular stuff, the mental status, behavior, affect, orientation, language, memory, thought content, and judgment. So laboratory testing, this is an area of a lot of, in my opinion, I put them in italics because I think that they're incredibly loose and goosey, and it depends which attending you're talking to and what facility you're sending them to. And the number of times we've had patients boarding in a small community hospital for 48, 72 hours, and they want a new tox screen on them, or they want new alcohol blood levels, could drive you crazy. As people who I've trained and people who I've worked with, they know I have a very low tolerance for this kind of nonsense. However, I have had patients that were in the quiet room who came in sober with no alcohol and 48 hours later were drunk. Their visitor came and brought them alcohol. So it can happen. So, for you, I want your careers to be long as mine is, which I'm looking at 30 plus, and take the path of least resistance. You can have an argument with them and you can discuss the pros and cons in the literature, or you can just get the stupid blood test again. It's really a decision that you're going to make on your own. I'm sure it's going to be the good decision for the patient. Let's change gears a little bit. One of the things that no emergency medicine practitioner ever wants to miss and send home is a suicidal patient, because I've had colleagues who did, and the aftermath of their mental health as a result of this is crucial. And so it's an eighth leading cause of death in the United States. It is only going up. We're looking at 30,000 deaths a year directly attributable to suicide. It's higher in the older population, but it's also pretty high in adolescents and college students. So there's two areas that you need to think about it being pretty high. If you're in doubt, please listen to me. Err on the side of caution. If you are a young attending or get a second opinion within the emergency physicians. Ask your friend down the hall. Talk to somebody that you trust. Ask them to go see the patient. Number one, the patient likes being seen more than once, believe it or not, even when they are depressed and doing miserably, because they think you actually care. And number two, we have reverse transference, which is a whole nother conversation. So you want to be very careful that you don't miss something within a suicidal patient. This data is really old. I am not so sure it's particularly correct, but I couldn't find anything in the literature. And I did do a pretty deep dive a couple weeks ago. Women attempt it 3 times more frequently than men. Men are 3 times more successful. 2/3 of men commit suicide with firearms. I think this data is probably a little skewed, but I'm not sure. The major risk factors are all the regular stuff that you would say: older, depression, previous attempts is a major red flag. The other big red flag is a family history. Unfortunately, there's a lot of good data that shows if someone in your family committed suicide, you are at a much higher risk of being a suicide victim as well. So be sure to ask them that family history part. Patients who present to the ED with suicidal ideations, sometimes I'm sorry, I'm blanking on the word, but it'll come to me in a second. They have personality disorders that they'd use it to manipulate you. You want to be very careful of this. But if they have a good plan, and if they're making a good threat, you need to also take that seriously. Plans are always something. When I speak to an emergency psychiatric consult or something like that, if I say, they got a plan and it's a pretty good plan, they take that much more seriously too. So be sure to include that in your consult history. Explore the patient's understanding of the drugs that they happen to be on and which drugs they are taking, maybe prescribed or not. Because sometimes I've had patients say to me, I know that you have an antidote for acetaminophen, but I know you don't have a very good one for aspirin. And so those are both over-the-counter drugs. And it's a lot harder to get somebody on a dialysis who has an aspirin overdose than it is to just give them the medical antidote for acetaminophen. So remember that kind of stuff. Sometimes they're much more educated than I am. This is a classic out of Tintinelli. It hasn't changed. Sad persons. I'm not going to belabor it. They like to put numbers with stuff. They say if you have more than a 5 risk, if you have more of 5 of these, then you're at a high suicide risk. Take that with a grain of salt. So if you think they're at risk of harm, advocate for them to get admitted. Now, county is a weird place because you have a psych hospital that's adjacent. A lot of those patients go there. You guys don't see them in your training. But at downstate or if you go somewhere else, almost all of Long Island, there's so few psychiatric beds. My husband, who runs a gigantic mental health agency in Queens and Long Island, I was saying to him, but you guys have these respite beds. They can go for 28 days. They can be there. It's so easy. And he says, yes, but I'm funded for 10 beds. All of Brooklyn has 3 beds that you can actually get them to. So the most difficult part is getting them into those beds. So you really want to think about that. Some psych units like to do no harm contracts and then they discharge them. They are not legally binding. I try not to get involved in them. That is a decision that you and your attending will make when you're dealing with them. I'm not going to go into medical clearance because I told you I was going to do that at the end of the lecture, but whatever that hospital wants in order to transfer them, give it to them. It's not worth you getting as many gray hairs as I have fighting with them. So this is a decision tree and it's pretty complicated. So I'm going to take it one at a time and we can go through this. So if they have psychotic behavior, hallucinations, delusional, if they're disorganized is a really good key. Or if the behavioral is strange, the family is bringing them in saying, hey, they've always been weird, but this is extra weird. They have a marked disorientation, confusion, and fluctuating consciousness. Please think delirium and dementia first. If they have a drug or physiologic or medical condition, then you want to think about the next one. And if this patient has an exclusively during a depression or a manic phase, then this is a brief psychotic episode. Does not mean they don't need admission, but it's not a long-term psychotic episode. And that's often why family members will bring them in. And then if they have a limited, non-bizarre delusions, this you will see in, for a long time, I was board certified in hospice and palliative care, and it's not an unusual thing. Parents of children who die violently often will have delusional disorders for the first 6 months after that child's death. You need to be very well aware of it. We usually try to counsel them on that and help them with it, but it is not, I am sure that my daughter is walking into my room every night when I go to sleep, therefore I can't sleep, therefore I have sleep deprivation, therefore I have this delusional behavior. That is common. And if they're coming to the emergency department, be compassionate and really help them, because that first 6 months after children's death is horrific for these patients. If the duration is less than a month, then we just call it a brief psychotic. And if it's more than 6 months, we're looking at schizophrenia or a schizoform disorder. So this is a little kind of a decision tree. Schizophrenia is the most common psychiatric disorder internationally. About 1% of the population have it. Usually it comes in late adolescence and early adulthood. It comes when people are when their frontal brain is finishing up. Your frontal brain and your cognitive decision-making really is completely formed at, believe it or not, age 24. And so as a result of that, then they lose a lot of that cognitive ability, because at that point is when they're exhibiting their schizophrenic behavior. So they have a very hard time with normal behavior that you would expect in someone of 30 years old and issues like that. It worsens with psychosis. They usually have very little insight. Their suicidal behavior is not particularly common unless their voices are really bad. It's okay to ask them who the voices are, how many voices there are, what are the voices saying to them, and what's going on. Sometimes they're on a lot of drugs, and you're going to need to call your toxicologist about them. They have very poor judgment and they're disorganized. They truly do believe that the walls are talking to them. They do not believe that they're crazy. So these are the symptoms of them. Greater than 6 months. I talked about the fluctuation in cognitive behavior. They are disorganized, bizarre, and eccentric. They have very poor social interactions. And I hate it when Tintinelli says this, or Harrison said it too. I went and looked at a couple of the big textbooks that we refer to, disheveled appearance. I think that's not very nice, but anyway, that's what's going on. Medical clearance, and we're going to talk about that a little bit more. I know I'm teasing you on medical clearance, but it should be directed to the vital signs. If they're agitated and suicidal or homicidal, there was a patient who from about 2003 to about 2014 came into downstate on a regular basis. His mother would bring him in because he couldn't be around her other children because he was just so violent. And he would get admitted for 28 days and then he would be sent back home again. Those kinds of things you need to think about. Always go for chemical restraints before physical restraints if you have a chance. They work better. They're calming to the staff as well. They require less resources usually, and you want to go for them. That doesn't mean that there doesn't come a time where you say, that's it. It's physical restraint time. And that's something that you'll work out in your clinical as you see more and more of these patients. That's why we do shifts. That's why we see people. the more and more patients, then you get better and better at understanding when it's time to get out the 4-point restraints. Can't do across their chests anymore. There's lots of rules with that for very good reasons. And I mean, I'll be the first one to tell you, I've had patients flip their gurneys on top of themselves and hurt themselves, and it gets to be a whole nother conversation. So be mindful of restraints. That's a different lecture and one that we can talk about. Antipsychotics, they're changing all the time. You just need to keep up with what is the antipsychotic du jour of the psychiatrist and the psychiatric team that you're working with. In the emergency department, haloperidol is still used with Ativan, we're still doing it. It is not a good long-term drug. It is a pretty darn good drug for chemical restraints. It's worth considering that a brief reactive psychosis or an acute break after an emotional or traumatic event can last up to 2 weeks, and these patients may need, and it could be confused with schizophrenia. We are seeing this from returning military sources who have had very stressful environments, who are also in the services between the ages of 18 and 30, and they come back and they are having a hard time with that. People who work in the VA see that's a lot more than we do, but be mindful that this is also something that can happen. The next one is depression. It's a functional disorder. It's a mood disturbance. They say that 15 to 20% of Americans suffer from major depression during their lifetime. These suicide rates are high. They can be as high as 15%. They can't stand the idea of being so depressed. The other problem with depression is once the medications kicked in, they also feel good enough to act on their suicidal ideations. So you need to be very careful with these patients as well. This is one of the signs and symptoms for it, sleep disorders, appetite disorders. I'm sure that this has been covered before, and I want to get on to the next thing, and I hate people who go over on their lectures. So, anxiety, I'm a baby boomer, so I get a little annoyed with all this, all these anxious kids, but, I can say that now that I'm retired and emeritus, I guess, but I'm not supposed to in a lecture. Anxiety disorder is very, very real. And it's something that you're going to be seeing more and more in your career. So persistent worry and tension and free-floating anxiety and, social media and all the stuff that works with it. That is something that its symptoms are more continual. It is not particularly difficult to treat. It is something that follow-up care is really appropriate for. But the one that I worry about is people with panic disorders, because these are recurrent. They're very severe. There's a surge of anxiety or dread. Their symptoms develop over minutes. They're unprovoked. I am sure someday somebody's going to do the research. There's some chemical thing going on. These people kill themselves because they can't stand the idea that they don't know when the next panic attack is going to come. Take them very seriously. Be very nice to them. They don't like it at all. Not that you're not supposed to be nice to the anxiety people, be nice to everybody, but the panic disorder, these people are really suffering. And we at 3 a.m. they're not my favorite patients to see. Substance-related disorder, this has been covered in many other places, and I really thank Noah for his excellent lecture. Also, the first lecture this morning on ethics, this is, one of these areas where your ethical decision-making really does matter. Don't forget the multi-axial psychiatric assessment. This is like being able to talk to an orthopedic surgeon. You need to know how to describe a fracture. You need to be able to talk to your psychiatrist on the 5 axes. It's now DSM-5-TR. So it changes about every 2 to 3 years. They change it. They put a lot more stuff out of mental disorders into personality disorders. And you really need to be knowledgeable of this from an emergency medicine point of view so that you don't look like an ill-informed person when you're talking to your consult service. So let's change our outlook. Receiving medical evaluation is often called medical clearance. This is a bad term and it should not be used. And I'm pretty concrete in a few things, and those of you who I've trained know that, or I've worked with know that, but this is one of these terms that is not good. It's not good medical legally. it's not good healthcare wise, and it's really difficult for you. So the responsibility absolutely rests with the ED person, that this person is safe, and think of them when they're going to the psychiatric unit as the same as going home. Are they safe to go home? The chances of getting a medical doctor in a psychiatric unit takes hours. They're not, that is not their goal. That is not what they're about. And so they are counting on us to really make sure that what happens. It's a small amount of the time, but it really has to do a lot also because these patients, their length of stay in the emergency department is tremendous. Now, this data is from 2024, so it's pretty good. It is considered a really important part of the ED encounter. They're really looking at you and coming up at you to really make this, but there's no agreement with psychiatry, with emergency medicine, with internal medicine on what the proper exam is, the role of laboratory testing, or proper documentation process. None of this is uniform. So it's going to be wherever you practice, unique with who you send to. And if you're like most hospitals, they send to 6 or 8 different psychiatric facilities. They send where someone will accept them. And so you're going to have a change. So if they're going up to Gracie in Westchester, or they're going over to Long Island, or they're going, to across the street to county, a lot of it'll have to do with their insurance reimbursement, but also it's going to completely change what that facility wants from the emergency department in their medical evaluation. It really is used to determine if these people are safe. And I already said that, and I'm sure you understand that. So the assessment is under EMTALA. So you need to think of this the same as EMTALA, which means that the person that signs that says that they're safe to go is guaranteeing they're going to live when they get there. So that is what EMTALA is really about. Now, it started out with labor and delivery in the early 70s. No, that's not true. Early 80s. And but you want to really think about that. You're guaranteeing that when they go there, that they're going to be safe, that you have ruled out the medical things that could be going on with them. The schizophrenic population is getting older. They're living longer than they did when I was practicing. You're going to see them in their 50s, 60s, and probably even 70s. They are living longer. They have chronic medical illnesses as well that need to be taken care of. There are only 4 medical screening algorithms that have been proposed in the literature. They're all lousy. I'm not even going to review them with you. They were designed by the ED trying to transfer the patient out as fast as they can. I won't say anything about ASAP right here. And they're with the idea that they're going to an outpatient, they're going to go home, and then they're going to be followed out outpatient. We often, at least in my years, the 22 years at county and downstate, we rarely sent patient home. They usually, they did go for follow-up, but it was really very close. So you want to be sure of that. All of these were designed with very scant empiric support. There's no systems that supported these algorithms, which is another reason why I didn't include them. There is some, and I'm going to show you my references at the end. There are 8 recommendations. These are new from 2024. I think they're really pretty good recommendations, and I'm going to review them, and then we'll be done with the lecture. So the first recommendation is medically clear should not be used anymore. Not even what I used to use was they're medically stable for psych admission at this time. The term should be replaced by a real note, a transfer note explaining what was tested and what was performed, and whether or not they're stable in your opinion. The goal of the assessment should ensure medical stability to a non-medical unit. That means these guys don't even have angiocaths. They're not going to draw blood on these patients. They're going to go to a completely non-medical environment. To identify both potential causative factors and the ongoing medical problems, which may require. Most people have more than one thing going on. Psychiatric patients have medical problems. They need to be addressed. Then another thing in the second recommendation, that the ED is nonetheless responsible for the disposition of the patient to the location that can manage the patient's acute and chronic illness. This may mean either an admission to, they may be a psychiatric patient, but still admitted to, I don't know, screening or internal medicine, or you guys have those new units now. So something like that. Recommendation number 3, further medical evaluation is needed for new onset psychiatric symptoms after the age of 45, even if they have a clear prodromal psychiatric illness. And anybody over the age of 65, regardless of their psychiatric history. This is kind of a duh to me. Patients with cognitive deficits and delirium, obviously. Positive review of systems, obviously. Focal neurologic findings or head injury, pretty easy. Substance use or intoxication, also pretty easy. Decreased mental awareness or abnormal assessment on the mentation. This is not always easy to do, and it may take a while, and you may have to be patient. They may have, because a lot of these patients self-medicate. You may need to have them wake up before you can make this kind of event. If they have an immune suppressed status and if they have severe medical disease. Other findings that require further assessment, and that one is, if they're a trauma patient or something like that. Recommendation number 4, evaluation should include vital signs, history, physical exam. It's not always easy to do a physical exam on a psychiatric patient. You need to still do it. They still do need to get undressed. You still do need to look at their skin. These are important things. It's not fun. I don't envy you or me, but these are still things that need to be done. The history should include an assessment of illicit drug use if the patient is on medication and any adherence or inadherence to medication. Recommendation number 5, the patient should perform, when possible, additional testing for stability. The ED should perform it. Because psychiatric settings have limited capacity for further testing, realize that they may be a little unreasonable about what they're asking for. However, a patient has the protocols to maximize medical disease without the use of routine testing. They don't routine, and what this is really, this recommendation number 6 is really saying is, you don't have to scan everybody's head. That is not appropriate. You do that if they have a reason to have it, because there's 0 or no positive outcomes on those. This one I already talked about. Also in number 6, psychiatric patients are disproportionately boarded in the emergency department. This is nationally and internationally. They get worse in the emergency department. They don't get less psychotic, they get more psychotic. They often get ignored there. They get ignored by us, they get ignored by medicine, they get ignored by psychiatry. When they're having a fit after being there for 96 hours because they got there on Thanksgiving and they can't find a bed for them until Monday, they have pretty good reason to be psychotic. Go in and treat them and medicate them and be nice to them. Remember that. Boarding is not fun. We don't like to be there more than 10 or 12 hours. They don't want to be there either. So be nice to the boarding patient. That's the last sermon I'm going to give today, I promise. Many psychiatric patients do not receive care in the emergency department. Get the psychiatrist to come down and write the meds. Recommendation number 7, disputes can be minimized if you speak directly with psychiatry. Don't talk just to the social worker. Don't talk just to the person who's talk to the psychiatrist. It's not easy. They don't find it easy to talk to us either, by the way. So be available if they're on the phone. Then the next thing is routine laboratory testing to detect medical disease has not been shown to be effective or cost effective. I say that, and that's all well and good to say, but there's a lot of institutions. They're not going to take them without a CBC. They're not going to take them without certain drugs. Get the labs for them. It's, you're not going to win this battle. It's been 50 years. Recommendation number 7, drug screens are really, they're not particularly great. They are stigmatizing to the patient. It can be really difficult to get them, but I have not known in my 30-something years for the psychiatry to take them without them. So cross that bridge. Sandwiches are really good ways to get some of these things done. Um, Neuroimaging is really, that's one that I think that I would draw a red line in the emergency department. If they don't qualify for neuroimaging, it should not be done. Recommendation number 8, and this is the last one, there is a surprising lack of research on this topic. If you're interested in this at all, you could really get a lot of research, and especially at county and downstate. There's been one systematic review, and most studies in the literature, as it stands today in December, oh, well, that's not true, in October of 2025, they're non-randomized and they have incredibly high risk and bias. And it's a really good area to look at and to be involved in. With that, I want to thank you. This is the main paper that I used for the 8 recommendations. It's really a nice paper. And these are my other references, which will be available. I want to thank you for your attention. I have a really warm spot for downstate, and I'm always excited when I get to come back and see you guys and share emergency medicine. So if I don't know what our timing is, I think I'm 6 minutes over. I apologize. And with that, I'll turn it back to the organizers, unless somebody wants to send anything through the chat, and I'll stop the screen share. And I think that's, you guys could take over. There you go.
Great. Thank you so much, Dr. Arquilla. Really appreciate it.